Okay, we will give everyone a few more minutes to get in. Good afternoon, everyone, and thank you for joining us. I'm Danita Walston, Associate Network Director of the Southeast Regional Clinicians Network and the National Center for Primary Care here at Morehouse School of Medicine. On behalf of Morehouse School of Medicine and the United Health Foundation, I would like to welcome you to Digital Health Equity, Solutions for an Equitable Future, Digital Health Tools, and Primary Care. Just a few quick housekeeping notes. Closed captioning is enabled, and you can access the transcript using the button on the bottom right of your Zoom screen. There will be time for questions from the audience after the panel. If you have questions throughout the event, please use the Q&A button at the bottom of your screen. Today, we're going to reflect on the dramatic effects the COVID-19 pandemic has had on healthcare professionals, practices, health systems, and communities. We will highlight some of the challenges the pandemic presented and also focus on the opportunities for advancing health equity and lessons learned. In partnership with the United Health Foundation, we launched the Digital Health Tools Study in 2019 as an effort to assess the gaps in adoption of digital health tools by primary care clinicians serving underserved communities. Little did we know at the time that the world would be upended by a global pandemic. Despite COVID-19's best efforts, we had more than 1,200 clinicians participate in this study, and we found that these clinicians' resilience in the face of tremendous challenges was remarkable. Today, we are incredibly honored to hear from dynamic, humble leaders representing every aspect of the health system, including policymakers, clinicians, innovators, and patients. First, we are so grateful to have recorded remarks from Congresswoman Nekima Williams, who represents Georgia's 5th Congressional District, which includes Morehouse School of Medicine. Congresswoman Williams has been a fierce advocate for social justice, women, and families throughout her political and professional career. She's also one of the co-sponsors of the Connect for Health Act, a bipartisan bill that would expand access to telemedicine in Medicare. Without further ado, let's hear from Congresswoman Williams.
I'm Congresswoman Nekima Williams, and I have the honor of a lifetime representing Georgia's 5th Congressional District succeeding my friend, mentor, and predecessor, Congressman John Lewis. Morehouse School of Medicine is located right in the heart of Georgia's 5th Congressional District. For 46 years, Morehouse School of Medicine has played a vital role in ensuring access to healthcare for communities that have traditionally been underserved, in particular, communities of color. I want to commend the Morehouse School of Medicine for everything that you've done over the years. I want you to know that I'm happy to stand with you and find more ways to provide healthcare for those who need it the most. I also want to congratulate the National Center for Primary Care at Morehouse School of Medicine. Your work exemplifies Black excellence, and now you're the only congressionally recognized research center focused on primary care. While we can't be together in person for today's event, I'm hopeful that by following the science, that we'll soon be able to gather again safely. Morehouse School of Medicine has been critical in making sure that that happens, from conducting research on the efficacy of the Moderna vaccine and deploying mobile vaccine units to reach every community. Morehouse School of Medicine, alongside the Atlanta University Consortium, has been on the front lines working to crush COVID-19. As a COVID-19 survivor, I know how terrifying COVID-19 is, and I wouldn't wish it upon anyone. As everyone here knows, we aren't safe from COVID-19 until all of us are safe. The only way that that's going to happen is getting everyone vaccinated. I and my House Democratic colleagues and President Joe Biden are working on just exactly that, but we can't do it alone. We need strong partners on the ground, and Morehouse School of Medicine is one of those partners. So thank you again for your tireless work keeping our community safe. The COVID-19 pandemic laid bare the inequities in our healthcare system that all of us here know too well. That's why I was excited to see that today's theme is digital health equity. Digital health equity is sure to be one of the most important new vanguards as we create a healthcare system that works for everyone, no matter your bank account, no matter your zip code. That's why I co-sponsored the Connect for Health Act, so more people could have more ways to get the medical care that they need, specifically with telehealth services. Telehealth services provide greater access and more equitable care for everyone. Increasing access to medical care promotes greater public health to underserved people in rural areas, as well as metropolitan areas like Atlanta. Additionally, telehealth visits enable people with chronic conditions, differently able communities, and older Americans to avoid exposing themselves and others to COVID-19 while still getting timely care. More than 25% of Medicare beneficiaries had a telehealth visit between the summer and falls of 2020. And as we modernize in Congress, we must also work to modernize other structures working for the people. While we need to increase access to digital health equity, we must also solve the foundational issue that too many of my constituents face. Y'all, they simply don't have access to any health care. I know personally that access to quality, affordable healthcare can literally save your life. I've been in the situation that too many people find themselves in. Not many years ago, I was uninsured and I was in a car accident. I declined to be transported to the hospital by ambulance because I was afraid of the final bill. I also saw how my mom struggled in her final years as she battled stage 4 colon cancer. I carry those lived experiences with me every day in Congress. That so many people struggle every day to afford the healthcare they need, y'all, is shameful for the richest country in the world. Healthcare is a human right. I know that House Democrats are united in expanding access to healthcare and seeing through the promise of the Affordable Care Act. But today, because of purely political behavior of governors in states like Georgia, the promise of the ACA isn't being realized for many of our most marginalized constituents. The Affordable Care Act was designed to expand Medicaid coverage to folks whose income fell below 133% of the poverty level. This has already happened in 38 states, 38 diverse states like Washington, D.C., California, Oklahoma, Kentucky, Arkansas, Montana, Pennsylvania, Maine, New York, and many others. But y'all, 12 states, including my home state of Georgia, have held out. And despite including incentives for these states to expand Medicaid and the American Rescue Plan, they've still held out on doing what's best for the people. We know that Medicaid saves lives, and we can't wait any longer for the people in these states to get coverage for Medicaid expansion that they need. And y'all, they would otherwise get it in 38 other states. That's why I co-sponsored the Medicaid Saves Lives Act. The name of this legislation says it all. Medicaid saves lives. When passed, the bill would create a federal Medicaid lookalike program that would cover over 4 million people who've been left behind across the country, including over 500,000 Georgians who've suffered because of a lack of leadership, political will at the state level. This critical legislation will secure the promise of the ACA and get healthcare coverage to people no matter their zip code or bank account. And as anyone who has had to fill a prescription knows, drug prices have skyrocketed for years, and often with no relation to any economic factors. That's why I've co-sponsored several pieces of legislation to lower drug prices, including the Elijah E. Cummings Lower Drug Costs Now Act. Healthcare doesn't stop when you leave your doctor's office, and being able to get the prescription drugs that your doctor prescribes must be included in any healthcare changes that we want to see. The rising cost of prescription drugs can jeopardize any reforms that we implement. By putting medicine out of reach, whether it be rising costs for prescription drugs or medical treatment, no one should be denied from getting the resources that they need to live healthy lives. I want to be absolutely clear to everyone listening right now, just in case it wasn't obvious. In Congress, I'm committed to the promise of universal quality healthcare coverage, and I'll fight every day to ensure that people can get access to the medical services that they need. We must make sure that healthcare is a right, not a privilege. But y'all, I'm not stopping there because there is still so much more left to do for the people. On Monday, I was at the White House at the signing ceremony with President Biden and Vice President Kamala Harris as we signed into law the transformational bipartisan infrastructure bill. This once-in-a-generation investment in our physical infrastructure will help bring our outdated physical infrastructure into the 21st century. Now that we've invested in our physical infrastructure, it's time to invest in human infrastructure. We have to make those same transformational investments. I'm in Washington this week, beginning to finalize President Biden's Build Back Better Act. This is the investment in America's families that we've needed for decades. Included in President Biden's framework for the Build Back Better Act are many of my policy proposals that will help Americans lead healthy lives. We're still working out the details, and I know you've seen a bit about it on the news, but I would be so proud when we pass the Build Back Better Act because we're going to close the coverage gap permanently and extend the children's health insurance program. We're ready to reduce health premiums for more than 9 million Americans by extending the expanded premium tax credit. And I know from working with domestic workers that access to home-based care is critical to healthy lives. That's why I push to improve Medicaid coverage for home-based care services for seniors and individuals with disabilities. And I'm happy to say that it was included in the framework for the Build Back Better Act. And I've heard from audiologists in my district on how audiology services are out of reach. And y'all, we're finally going to expand Medicare access to hearing services. I'm proud of everything that I've done so far in Congress to create an equitable future for our healthcare system. And I'm proud that we have a president, a vice president, a speaker of the House, and my congressional colleagues that realize the importance of our work in this moment. And I know that working together with everyone here and partners like Morehouse School of Medicine will create an equitable healthcare system that works for everyone, regardless of their zip code or their bank account.
Many thanks to Congresswoman Williams for these inspiring words and support for Morehouse School of Medicine and the National Center for Primary Care. Now we will hear from the Director of the National Center for Primary Care, Dr. Dominic Mack. Dr. Mack is a professor of family medicine and has practiced in Georgia for over 30 years, serving in various leadership roles within nonprofit and for-profit organizations, including many years of service in federally qualified health centers. He leads NCPC's promotion of health equity and population health through the development of strategies to further research, innovations, and training that advance primary care systems. Dr. Mack is also the director of the National COVID-19 Resiliency Network, a partnership with the Office of Minority Health, organizations, and communities across the country intended to mitigate the disproportionate impact of COVID-19 on racial and ethnic minority and other socially vulnerable communities. As an early adopter of health information technology and leader of digital health tool study, Dr. Mack will share his perspective on digital health equity. Dr. Mack, the virtual floor is yours.
Thank you, Ms. Walston. And we thank Congresswoman Williams for her comments. And I'd like to, she made a statement I think I can build off of as we pivot to digital health, which we're talking about today. As we modernize in Congress, we must also work to modernize other structures working for the people. I think we must taste this approach when we talk about the strategies for implementing technology and digital health in disproportionately impacted communities. We must understand the foundation of inequities within communities in order to help those communities. And those foundations of inequities are different as we go to those communities. If you look at the slide, you'll see technology. And what we're trying to do is move technology to its rightful place in these communities. Today, technology is mostly developed for Fortune 500 companies or the larger organizations, rightfully so in a business model that seeks profit. So a lot of times it's a retrofit for these communities. But this shows you we should look at the communities first, the culture within the communities, looking at linguistic differences, cultural differences, and right fit for those communities. What are their inherent risks that are unique? And then develop technology that fits those communities and can be expanded to other disproportionately impacted communities. That's how we get to care. We always say that technology does not provide care. There's a healthcare system where we use technology, machinery, but we have providers. And primary care, the provision of primary care is a focus of ours. So how do we develop an infrastructure, including a technology infrastructure, that helps us to overcome those disparities within the care? There are a lot of clinical stories. You can see some of the mental health stories of people who don't have care. When you look at folks who are homeless, it's not often that high tech. Sometimes it's low tech that can reach these communities. And we must really look at that. So what is the rightful place of digital health when it comes to these communities? And part of the digital health tool study is to question and to ask not only the community, but the community of providers, hospitals, those who are healthcare leadership, to ask what's working within these communities and what's not. But there's a challenge left for us even after the conversation today. There are people who are not represented. There are providers who are not represented. And you'll see that when we give you the data around rural health, et cetera. We need to continue to reach out and to engage those under-resourced providers, rural areas, urban areas, hospitals that are closing down in those rural areas, and actually understand what are the needs of the communities and how can we better equip these under-resourced health systems with digital health. So that's our challenge past today. But today we're going to discuss the findings of this unique study. We want to thank the United Health Foundation for really resourcing us so we are able to do this study. And I hope you enjoy the conversation today, and we can continue this conversation after we have our panel experts speak to you. So I'll turn it back over to Ms. Walston and to continue the program.
Thank you so much, Dr. Mack, for sharing your insight and experience with us. You provided us with lots to think about and a really nice platform for the discussion that we will follow today. Next, we will hear from Mr. Mitchell Blunt, Senior Research Assistant here at the National Center for Primary Care. Mitchell has provided key leadership and execution of the Digital to Health Tool study over the last 2 years. In fact, today is Mitchell's 2-year anniversary with the NCPC. We are so fortunate Mitchell will be providing you with the findings for the Digital Health Tool study. Mitchell, I turn it over to you.
Thank you so much, Danita, for those wonderful and kind words. It's definitely a great moment for me today to be able to present the findings from our Digital Health Tool study. So, as Danita said, I am the Senior Research Assistant here at the National Center for Primary Care. And I'm just going to be laying the foundation for our panel discussion and sharing some of the findings with you. So we are Morehouse School of Medicine, located here in Atlanta, Georgia. MSM is one of 4 historically Black medical schools in the nation. And our vision is leading the creation and advancement of health equity. As one of the main research centers here at MSM, the National Center for Primary Care serves as a national resources for frontline practitioners, educators, researchers, and policymakers who impact our primary care health system. NCPC, as what was Congresswoman Williams mentioned, is the first congressionally designated center to develop programs that strengthen the primary care system through health equity and sustainability. So before we go any further, you're going to hear us use the term digital health tools or DHTs. And so I just wanted to give a broad definition of how we talk about those tools. And you will see from the screen on just an example of some of the tools that we had in our survey, but this list isn't all encompassing. And as you look at these tools and as we go through our discussions today, I want to pose this question to you. And I want you to hold on to it. Why are digital tools so important in achieving health equity? During the pandemic, there have been numerous studies and reports being conducted that address the impact of COVID-19 on existing health disparities in rural, underserved, and underrepresented communities. Inequitable access to broadband and internet for Black and Latinx communities, food insecurities and food deserts in rural and underserved populations, and cultural insensitivity and racial biases, just to name a few, were exacerbated due to COVID-19. The pandemic has also highlighted, and in some instances, really transformed and reinvented the wheel for some other inequities in the clinician workforce, including racial discrimination and mental health issues, the need for access to counseling and therapy resources for our frontline clinicians and healthcare workers. Before the pandemic, we know that clinicians were experiencing burnout and frustration using digital health tools, especially with electronic health records, due to the lack of integration into their existing workflow and their existing tools that they may be using. Numerous barriers, including numerous alarms and alerts that some deemed unnecessary, and the time that it just took away from actually connecting with patients. Clinicians to continue to experience the same or worsening levels of burnout due to data entry, data fatigue, and lack of automation, just to name a few. We saw record numbers of clinicians and healthcare workers retiring early, quitting their jobs, and switching careers for a different quality of life. Even through all these barriers and everything that clinicians face, they continue to provide the best quality of care possible to their patients. The rapid adoption and use of digital health tools served as a catalyst to reach many more patients who may not have been able to receive care prior to COVID. This rapid uptake was accelerated by state and federal policy changes. Some of these changes included enhanced reimbursement rates for telehealth, reduced or waived cost sharing for patients, and permitted community health clinics such as federally qualified health centers or rural health clinics to offer services that once were not available to them. The patients that benefited most from these services and the greater availability of these services were those who were having difficulty leaving their home because of chronic illnesses, those who are facing transportation barriers, or those who live in a location that it just has poor access to great quality of care. So as Dr. Mack mentioned, in 2019, the National Center for Primary Care and Morehouse School of Medicine partnered with the United Health Foundation, really to examine how to make digital health technology more accessible and usable for residents of urban and rural and underserved communities, with a particular focus in Georgia, Kentucky, North Carolina, and Tennessee. Our digital health tool study builds upon previously conducted research that found primary care practices, and especially in rural and underserved communities, really struggle to adopt digital health tools such as electronic health records and telemedicine compared to higher resource settings. We know that digital health tools are critical to achieving and advancing health equity, but only if they are accessible to the clinicians in the communities that need them the most. So we went about our study using a multi-method approach to identify the barriers and facilitators to digital health tool adoption and use at multiple levels. So we examined the individual clinician level, looking at the overall practice level, trickling down and widening to the population and system and policy levels. For the individual and practice levels, we conducted a survey and focus groups assessing clinician demographics and digital health tool use across multiple practice settings. For the population and policy levels, we conducted secondary data analysis using Medicaid claims data and conducted roundtable discussions with policymakers, health system leaders, administrators, and staff in small practices and rural hospitals. The continued work we do will inform interventions on multiple levels, each supporting the adoption and use of digital health tools to advance health equity. Technology use and the digital divide were frequently discussed in our focus groups, as you can see from the images, the quotes that are on the screen right now. Clinicians highlighted challenges with engaging patients with digital health tools due to language barriers, including those in high Spanish-speaking populations. One major theme discussed was the importance of the patient-clinician relationship and how much it matters. Regardless of how great the technology is, the relationship is the foundation of care. So technology is an aid, not a substitute. We also heard stories about the lack of autonomy in decision-making by clinicians on the digital health tools that are used in practice. We heard from many clinicians who do not have a leadership position in their practice of how they would give ideas of the types of tools that would integrate well with their existing practice and then existing workflow. But due to time and costs and other decisions made from senior leaders and IT staff, those recommendations often went unheard and often hit a brick wall, as one clinician actually stated. So via our surveys, we heard from clinicians from across multiple specialties, years of experience in practice settings, with most of our clinicians actually being in a hospital or outpatient primary care setting. Almost all of our clinicians stated that they use digital health tools within the past 5 years, and that was really encouraging to see. But they did have some barriers. The top 3 barriers to adoption of tools were time, the time that it actually takes away from the patient and the time that it takes to actually utilize the technology, the expanding costs of the digital technology, and the limited workflow. It doesn't really integrate well into their existing workflow and practice. But there were some supporters. Clinicians stated that in some instances, it was very easy to integrate the tools into their existing workflow. And 2 of the major things were that it met the patient's need and improved the patient's health. So clinicians often stated that even though they would sometimes suffer, the ultimate benefit was that it was meeting the patient's need and the patient had a better quality of care. The most commonly used tools by clinicians were electronic health records, telemedicine, and patient portals. However, as you can see, mobile apps, wearable devices, and prescription drug monitoring programs were less often used. So we asked the question, why is that? I think we'll leave that to the panelists to ponder on, and let's go back to that question. So almost 70% of our clinicians reported using telehealth because of the COVID-19 pandemic. And 54% stated that they used telehealth for the very first time due to the pandemic. Clinicians who used telehealth for the first time stated that they used them to treat COVID-19 patients, with the majority using them to treat COVID negative patients, which is very encouraging to see. They also used them for training purposes, or training their new staff or interns, and also to limit clinician and patient interactions. So having to hold appointments outside of the office. So what does all of this mean? Mitchell, you gave us all of these wonderful figures and all this data, but what can we do with all of this? And I will answer that question. If we want to improve the adoption and use of digital health tools by primary care clinicians with the intention of advancing health equity, our findings suggest that we must first address workflow barriers. The multi-click nature of electronic health records, or the lack of reliable, usable data of health information exchanges, are time-consuming and resource-intensive. Clinicians need to be involved in the inception of these digital health tools to be more aligned with their workflows. Clinician leadership need to take into account the voices and opinions of clinicians in non-leadership positions. In many instances, those clinicians feel very disconnected from the tools that are used. And also, clinicians need to better engage with their patients. The lack of access to internet, Wi-Fi and broadband, or other hardware and technologies really pose many barriers to equitable access to care. However, as was mentioned earlier, clinicians were very resilient and very creative during the pandemic. We heard stories of clinicians actually using tablets and taking them out into the parking lots of their office so that they can actually conduct a telehealth appointment with the patients. So they are being very resourceful. For our patients, patients need culturally tailored technology. In communities with a high Spanish-speaking population, for example, many patients found it difficult to find a clinician who is Spanish-speaking, or if the actual practice had translators available. Patients need trust. They need to be able to know that they are getting the same quality of care via a telehealth appointment or any type of appointment using their digital health tools as they would if they were in the actual practice setting face-to-face. But we also found that technology issues were not age dependent. Although some clinicians did adapt very quickly to digital health tools, patients of all ages were left struggling and sometimes in the dark on how to sign up and use the technologies. However, there were cases and many stories of patients who were sometimes well into their 80s walking into their actual practice prepared with their email address and all the information that they needed to sign up with the for the patient portal or sign up for the new technologies that were implemented. And finally, we need to address payment policies. Parity and reimbursement by private payers as well as commercial payers, and addressing the incentive gaps. We heard from one clinician and a very powerful quote, incentives lead to consideration and initiation, but not prolonged participation. So I'll let you ponder on that. These payment policies should support the current workforce by reducing burnout, providing meaningful tools for clinicians to improve relationships with patients and engage others. We also need routine guidelines and protocols for digital health tools that become standard of care. So as we conclude this portion of our discussions, I just want to take the time to thank the entire Digital Health Tools Study research team and all the clinicians who participated in our study and all of our partners who helped us to get the research out. And also to the United Health Foundation for their continued participation and support. Thank you all so much.
Thank you for that, Mitchell. I'm so thrilled to introduce this esteemed, our esteemed panel. They'll share their perspectives and reactions to the digital health tools findings. At the end of this discussion, we will provide an opportunity for a few questions from the audience. If you have any questions, please enter them in the Q&A section. And now I invite our panelists to turn on their cameras. Mitchell, can you introduce the panel, please?
Most certainly. So as Ms. Walston stated, we're so thankful to have this esteemed panel joining us today. First, we have Dr. Angelica Jeter. She is the Chief Strategy Officer for the Black Women's Health Imperative. Dr. Jeter comes to us with a wealth of experience. She leads the organization's first national anti-racism initiative, an initiative primed to transcend traditional diversity, equity, and inclusion efforts by stimulating more visible systemic change in corporate policies and practices. Prior to this role, Dr. Jeter was the first Chief Health Equity Officer for the City of Atlanta, appointed by Mayor Keisha Lance Bottoms. She led the pandemic coordination team assembled in response to the COVID-19 pandemic and will share her experiences in that role today. Welcome, Dr. Jeter. Dr. Christy Henderson is CEO for MedExpress and Senior Vice President of the Center for Digital Health and Innovation for Optum Health, where she is creating a first-of-its-kind connected health ecosystem using industry-leading digital health tools and telehealth. Dr. Henderson is a nurse practitioner with over 25 years of experience designing, implementing, and optimizing the healthcare delivery system using digital health tools and technology. Thank you so much, Dr. Henderson. Dr. Odell Bonwell III is a pediatric specialist located right here in Georgia, and has over 18 years of experience in adolescent medicine and internal medicine. He is a partner and attending physician at South Atlanta Pediatrics and an investor at Kids Time Pediatrics. He is also a graduate of Morehouse School of Medicine and actually participated in the Digital Health Tools Survey. So thank you so much for being here, Dr. Barnwell. This discussion will be moderated by our very own Dr. Ann Gagliotti. Dr. Gagliotti is a practicing family physician and is an associate professor in the Center for Community Health Integration at Case Western Reserve University and the Population Health Research Institute at Metro Health Medical Center in Cleveland, Ohio. Prior to moving back to Cleveland, Dr. Gagliotti was the research director for the National Center for Primary Care and a medical advisor for the Digital Health Tool Study. Despite her move, she continues to advise the study and maintains a faculty appointment and affiliation with the National Center for Primary Care. So Dr. Gagliotti, I will put our panel in your very welcome hands. Thank you all so much.
Thank you so much, Mitchell. And I'm so excited to speak to this wonderful panel. I think that we have so much to talk about at the intersection of primary care, health equity, and digital health tools today. And listening to your talk, Mitchell, I just want to pause and acknowledge the amazing resilience of the primary care community, of our communities and patients who have navigated the multiple traumas of this pandemic with resilience and innovation. And so I think that really grounds our discussion well today. So as you all heard, this panel has really unique perspectives and deep experience in their fields. And so I am excited to sort of draw out that experience for our group today. Dr. Barnwell, this first question is for you. In your practice as a primary care clinician and as a clinician leader, if you could share a little bit about your experience responding to the needs your patients had during the COVID-19 pandemic, and how you utilize digital health tools in responding to those needs.
Well, thank you so much for having me on today, and really honored to be here. And this is an excellent discussion. First and foremost, COVID-19, as we know, affected everyone. It affected the community health providers. It affected as a pediatrician, it affected our parents. It affected our patients. Never forget March the 13th, 2020, I got a call from my partner and we had a decision to make. We're considering potentially taking a 2 to 3 month break from even seeing any patients because of the fear of contracting COVID, and parents didn't know what to think. And so COVID, as we know, that's already killed approximately 766,000 people. At that particular point, no one knew much about and had much awareness about the long-term and short-term implications of COVID. So at that particular point on that day, as a personal financial co-owner, we were considering shutting down and maybe not being able to pay our staff, maybe not being able to pay myself. And at that particular point, we had not ever used telemedicine as a digital health tool. We've been on electronic health records for about 10 years. But at that particular point, we did research, we pivoted very quickly, and we became creative and innovative And within about a 10 to 14 day period, we implemented telemedicine and established certain policies and procedures and protocols to be able to provide access to our patients. So with implementation of telemedicine, we provided access to our patients who, first of all, with COVID had a fear of coming in, had anxiety of being around other people. And so with restricted access to medical care, they didn't know what to do. So with digital health tools, we were able to enhance the overall quality of healthcare, provide triage through an interface. We essentially were able to also have people come by and do swabs and still triage them that way and take care of them via the digital platform. We're able to reduce people going to the emergency room, so reduce overall healthcare costs by seeing them virtually and providing reassurance. And then, of course, overall, we were able to financially be able to sustain throughout the pandemic in pivoting. We got up to about 40% of use of telemedicine visits with our overall schedule. But of course, our overall volume was down. But without digital health tools, I don't think we would actually be open in practice to this day.
Thank you so much for sharing that powerful story, Dr. Burnwell. I think under what I reflect on after hearing that story is just the relationships that were able to be sustained, right, with your patients and the families that you serve in a time that was just dire. But that also you were able to sustain yourself to be able to continue to take care of those folks. So it's a powerful story. Dr. Henderson, shifting to your perspective as a clinician leader and health system innovator, if you could share some stories about your experience during the COVID-19 pandemic, how Optum pivoted to support clinicians and patients during that time.
Yeah, thank you. And just thank you for having me. I'm honored to be among this panel and to hear the results from the study. Such important work. And, just as Dr. Barnwell, as you were speaking, I kept thinking through just the profound resilience. And we've heard that come out, but, necessity does drive innovation. And if we can find that silver lining from this tragic events that have that we've all been living for the last 18 months, really, we really will be able to redesign and rethink how care could be delivered in a more equitable way and using digital health tools to deliver quality care and reach people and reach the unreached as well. And so super excited to be a part of the conversation. And when I speak, I'll be speaking a lot from a system perspective because we're a very large system while I run a group of urgent care convenience clinics. They're in 16 states, and I'll speak to that specifically as well. But I'll be speaking from a systems approach to how we responded because it was quite phenomenal to watch just the amazing partnership and collaboration that happened across clinicians across the entire country. And I just get goosebumps really thinking about the work that everybody did. We knew our patients needed to continue to have care, and some of the very things that Dr. Barnwell was talking about, the struggles of, do we stay open? Do we stay closed? How do we reach people? And it wasn't all virtual either. And I'll speak to that in a minute because not everybody had broadband, not everybody had technology, but this was an important piece of the puzzle. And so during the early days of the pandemic, the first thing is that we had a digital response team that was stood up, and it was truly volunteers from across the company whose day job was no longer the same thing that it was, and of all different skill types to come together. And that team met and huddled every single day to quickly, over a period of just weeks, to get digital health tools in the hands of all of our Optum providers and clinicians across the country. Many had not used digital health before. It had been a novelty. Some had tried it a little bit, but it had not been mainstream. But when the clinics closed and patients needed our support and those that we serve needed our support, it was the way for us to reach people. So the first thing that we did was this digital response team work to put in the hands of our our clinicians and over 17,000 providers were handed digital health tools. We trained them. We stood up a 24-hour telehealth call center, and that call center was to support the clinicians because they also were learning how to use the tools, but more importantly, patients that had different levels of digital literacy and comfort with this, whether it was because of age, whether it was because of true comfort level using digital tools, or doesn't matter. It was there to be there to answer those questions and allow people to use it. So we had a 24-hour call center. We had digital health tools put in the hands of all of our clinicians. And during this past year, we saw over 1.7 million telehealth visits in our company, just in Optum. That was not the broader work by United that was even larger than that. Behavioral health, primary care. We were doing annual wellness visits. We were doing everything, trying to extend healthcare to those that needed it. The opportunity that we had then was to think, okay, we've mitigated the immediate need to get healthcare in the hands of people, but we still have other things that we've learned from this. One was we realized we had to send devices to some people. Some did not have the technology, so we would send it to some people. We had curbside telehealth where patients could get to the clinic. We didn't want to bring them in for the risk of exposure, but we would have someone bring out a tablet and could facilitate that interaction with a clinician that may or may not be inside the clinic, but still will be able to address challenges around broadband and access to actual technology. And then we just said, we've got to step back and think, what have we learned from this? And how do we want to redesign how, where, when people get healthcare? And all of this was not around just being able to deploy technology. It was about being able to build trusted relationships and help people get the care they needed in the manner they wanted to get it in. Some people wanted to come back into the clinic when we reopened, others did not. And behavioral health is a great example around being able to deliver much needed services and maybe help reduce some of the stigma and challenges we have with in-person care. And so today we're sitting here now with the Center for Digital Health and Innovation that is working to incorporate digital health tools across the whole system of care for ongoing engagement, never sacrificing quality or relationships. And so all of this, I anticipate, will go at the speed of the advancing technology, advancing broadband, aligned incentives and reimbursement and policy changes that we need to be really a permanent place and not just a waiver during a pandemic. And then most importantly, at the speed of trust, with that meaning clinicians trusting the tools, ensuring that they can deliver high quality care, but also for all the individuals that we serve, trusting this relationship and care being delivered through digital health tools. So we responded really rapidly, and it has changed how we do business going forward from what we learned.
Thank you so much, Dr. Henderson. I am struck by one thing that both you and Dr. Barnwell mentioned, which was the capability of the team and the system to implement and innovate rapid change. And I think, thinking about the new center that you are leading, I think sometimes when we realize what we are capable of as a team, you then can build that trust within your team to sort of see the possibilities and have the courage to take those next steps. It's wonderful to see your team taking that next step towards sustainability. Dr. Jeter, we've talked a little bit about the clinician perspective and the health system perspective, but I think you have some great insight into the community and patient perspective that I'm excited to dive into. We have heard this morning already about so many challenges that impact patients and communities accessing digital health tools, whether that's the digital divide or digital literacy or trust. What other issues are important to resolve or tackle to better support equity through digital health tools?
First, I have to say thank you to everyone for the opportunity to just connect with my Morehouse School of Medicine family and just to see you all and to really share this experience because it is very unique. There's so much to share. As Odell and Christy, they were talking, I started to have all these flashbacks of different moments from March. March was like the turning point for all of us. And I just think it's interesting when you talk about the experiences, especially when you're leading at the local level, to provide a little context for everyone. You know, through the city of Atlanta, the city does not lead the local health department. We don't have the health department. We lead through governance, through the funding, the policy, legislation, support, and we lean on those partnerships through the local and state health departments. And so that was the center of everything that we was doing and what really made it successful. And so when March 16th hit and Odell talked about his day, March 11th, for March 16th was the day that we decided to shut down the city of Atlanta. We decided to stop certain operations and really think about, you know, what do we do? When we talk about technology and different services, we were asking ourselves the question, okay, so who's in charge of getting people access to the internet? Who's in charge of getting people access to certain services and ensuring that they understand what's happening right now? And so a lot of the barriers that we were seeing, and although we don't have a health department, we did have our own clinic where we were caring for at least 6,000 City of Atlanta employees. So I can use that hospital in particular as an example, and I can talk a little bit more about what we did for residents as well. And so we had to think about the training of our providers and were they trained to adopt those new digital health tools that would be on the way. How many of the employees were actually utilizing the telehealth services that we had available to them, and then educating them, provide them, you know, that level of awareness about what is actually available to them. In the midst of them, they were still working. Most of us continued to work if you were working for the city of Atlanta. So their risk and vulnerability was still there. And so we were dealing with identifying cases, potential deaths of our team members, and trying to educate people about what they had available to them in certain services. And then leaning on the partnership of our local and state leaders, local and state health departments that I and the rest of the mayor's pandemic coordination team spoke with on a day-to-day basis. Dr. Henderson spoke a lot about those teams huddling consistently and figuring out what the plan was for that day, because we took those methods. We did the same thing with the city of Atlanta, but taking that approach on a day-to-day basis, sometimes hourly basis as it relates to COVID-19. And we had to think about the mental health and anxiety that people were facing when using those new tools. That a lot of it has been around for a while, but it was new to them. And having to acknowledge that was so important. And then thinking about the local leadership and advocacy around policies, funding, governance to support the use and adoption of digital health services to help people get engaged with testing, screening, and other care services, and also thinking about the lack of integration. So everyone was operating in so many different silos, and for a long time, even before I joined the city of Atlanta, we didn't have certain relationships. So part of my job was to ensure that we began to build those relationships. And COVID-19 kind of put us all in the same boat where we had to engage in a very meaningful way and partner in a way to really support and protect the health of City of Atlanta residents and really all across Georgia. And those partnerships were essential to get people access to what they needed. And so I heard you all taking notes. I'm a scientist, I can't help that. But thinking about systems, innovation, and collaboration, it was so important and set the foundation for what we did during that time, and helping to address those barriers and challenges that everyone else has talked about.
Thank you, Dr. Jeter. I think that all three of your responses really just, I think, illustrate Dr. Mack's point earlier that technology was a tool in service to the need of the community, and the rapid but very strong networks and relationships and partnerships that had to be built in a time of crisis. So we've talked a little bit, and perhaps a lot, about some of the challenges and barriers to rapid implementation, but also to just the day-to-day utilization of digital health tools. But if each of you wouldn't mind sharing a story that can show the success of digital health tool implementation for you or a patient or a practice or a system, and whether that's in the context of COVID-19 or in the context of another setting. Dr. Jeter, do you want to?
Sure. So it made me think about a couple of things. We leaned, again, heavily on the partnerships with our local and state health departments, and information sharing was essential. Health information sharing, understanding, and this is more of the surveillance information, but also having to identify those cases, that health information, and sharing those updates around what was happening with COVID throughout the city was so imperative to really understanding risk, vulnerability, where the cases were happening. And I remember a time when, as it relates to data in particular, we weren't aggregating the data by race. But those of us who do equity work, we know who was most vulnerable and who was being diagnosed most often. And so the health information sharing was essential. The lack of integration was a barrier, but it was essential for the success of what we wanted to do. And then when we think about what we were offering for residents, again, we did not lead a health department, but we utilized text messages, those robocalls, and connecting with the community. And I know tech is such a big part of our discussion, but we were doing a lot of advances around digital health, doing a lot to connect even residents with local clinicians who wanted to collaborate with us so they could actually get connection to those telehealth services, to telemedicine, and be able to have certain appointments. But we had to get back to the basics. We could not miss out on the opportunity to knock on doors, to educate people, to actually promote that awareness. I can't say it enough that awareness is the foundation for everything that we're doing. And I think very oftentimes when we forget to talk about awareness, then we have a large group of our community that gets left behind. You know, most of us have smartphones, we have certain resources, or we can easily text our providers and so on and so forth, but there is a large group of people who don't know what's out there. And I guess missing those opportunities to let members of our communities know, we could have missed a lot of people. Because of our actions and our approach, we end up saving at least 50,000 people from COVID. We know that for a fact. I'm sorry for the background noise. But getting back to those basics and being able to use technologies for information sharing, text messages to share information about cases, deaths, so on and so forth, helped us to be really successful.
Thank you so much, Dr. Jeter. I love that idea that, you know, again, you have the technology, it's built, but sometimes to connect people to that technology takes a low-tech solution and a relationship, a knock on a door, or a technology solution like a call or a text message. So thank you for that. Dr. Barnwell, any story that you want to share?
Sure. I would just like to highlight the point that healthcare and the delivery of healthcare is a human right and not a privilege. And so during the whole pandemic, because of digital health tools, we were able to deliver healthcare at the appropriate time, when the parents needed it, when they needed it the most, when still maintaining social distancing. So as we know, during the pandemic, I heard her say text messaging, utilize text messaging. 90% of people check a text within 90 seconds. And so we were able to have open communication with our parents We know during the pandemic, 1 in 5 people in a family have been affected by deaths or illnesses because of COVID. And so we saw in our behavioral sciences skyrocket in terms of increased anxiety, increased depression, proliferation because of the broken educational system, or at least the format in which a lot of children were being taught. We saw a rise in ADHD exacerbations. And so we were able to still be able to treat those patients and mitigate. We became, I hate to say it, psychologists and psychiatrists by default because of the lack of access that they had to the mental health specialists. So because of digital health tools and innovation, we were able to keep the connectivity open and once again, deliver the healthcare to the patients when they needed it the most.
That's a powerful, powerful message, Dr. Barnwell. I think that tidbit you shared about just being able to respond to, sometimes the power of being heard is so important, and that you were able to hear and build trust with your patients through that digital tool is pretty amazing. So thank you for sharing that. Dr. Henderson, any success story you would like to share with us?
Yeah, I'd love to tell a couple stories, but one just that it keeps coming into my mind as well as over last year. It was, and this goes back to Dr. Jeter, your comment around awareness. It was an immersion therapy for everybody around the possibilities of digital health. I think there was a lot of assumptions on a lot of people's minds around what it could or couldn't do, or, and I think it just gave us an opportunity to really have our eyes opened from individuals, from clinicians, from administrators, everybody around the possibilities, and that we could build trusted relationships, we could reach people and deliver quality care. So that's one, and I'll frame it with two stories. One from my work with Optum during the pandemic, and this patient actually was hesitant to go into in person, but more importantly was also hesitant to take off work to go get the care that they needed. And so this individual used our Optum virtual care services, was able to get an appointment quickly the same day to see somebody for her hand pain that she was having. It ended up being a really serious infection on her hand that could have progressed very rapidly to have a bad outcome. This individual was able to reinforce and educate how important that was to be treated, get her the care she needed, which ended up needing to be at the hospital, right? But these tools are not just about being able to see a provider and get the care you need with maybe a prescription or therapy or whatever, but it's also sometimes about just navigating and giving people confidence in their decision making around their own health. And so in this case, she was able to get the care that she needed. She didn't put off and delay the care that she was needing anymore. And her quote was around, she often looks at her hand and thinks about Dr. Miller that took care of her, sees her children and grandkids, and knows that this could have been a lot different if that had progressed. And so a very simple story, but one that really emphasizes that the digital health tools are about a relationship engagement and giving people access to the information that they need. And then sometimes it's navigation. The other story that I want to share is one from, I've been working in telehealth since 1999, and I started using telehealth in Mississippi and in the Mississippi Delta. And the reason I did that is because I had been working at the academic medical center there, and people did not have the access to the care that they needed, period. And being able to recruit and bring in the services that we needed in underserved or underpopulated areas was just not a reality. So telehealth was our solution. And one story in particular that I'd love to share, which was one that was a combination of digital health tools and local relationships with the health resources that were there, was a diabetes program. And we connected this community back to ophthalmologists, endocrinologists, and specialists within the academic medical center, but fostered a trusted relationship with a local primary care provider that was in that town. We gave the patients tablet that they took into their home so so we could monitor their glucose, that we could be there for coaching. The nurse was available and could interact with them so that when their blood pressure reading came back elevated, or their weight was increasing, or their glucose was elevated, there was a quick interaction, and the nurse was able to talk to them and even correlate actions to maybe changes in their vital signs. If they had just had a diet full of sodium and had some weight gain, they could bring more cause and effect and really make it into the reality of, how can I empower you to have the tools that you need, but more importantly, the information and awareness around how to manage your own health as well. So that program was incredibly successful. We published lots of results around it, and it's still active today. And it's not just for diabetes, but it was around bringing resources into the homes and into the hands of the individuals, using the local resources and augmenting and using the digital health tools to support engagement and relationship building. So just one example, and that was before the pandemic, and in an area where most would have thought we can't do it because of broadband and technology and digital literacy and all of that. And it was the very reason, that was the only way we could innovate and solve for our challenges and disparities around access to the services they need. So just wanted to share those two stories of how technology can really help us build those trusted relationships and get the outcomes we need.
Thank you so much, Dr. Henderson. Those are fantastic stories, and I think really illustrate some important successes around, as you say, how technology can be utilized to build relationships. Not to mention the relationship that was built with that community, who then had that in-home support and access. So I have one sort of last question for the panel. This is something I struggle with myself, and so I'm hoping you have some wisdom for me. I think, as you know, as we kind of continue the marathon that is COVID-19 in the healthcare system, we're all getting a little fatigued. As clinicians, as people. And I think that we have this amazing resource of the coalitions that have been built as a result of this pandemic. So the folks who have been convened, the group of people around the table that are clearly able to fix hard problems and work together. So my question is, how do we sustain those relationships and partnerships? How do we work through our fatigue to sustain those coalitions, to continue to innovate and implement and advance equity through digital technology? And I will open it to the floor as you all think of that.
A couple of things come to mind for me is, for one, we always have to think about who's at the table and continuing to add more fresh voices, perspectives to the conversation, because those new voices, those new perspectives will really drive the innovation to get you to think outside of the box. That's so important. The other thing that I think about is, and I hate thinking from the perspective of fear or concern, but a lot of us work in public health and healthcare. We are faced with the reality that this is not the last pandemic that we could potentially face, and that we are not out of it. There's still a lot of work to do. There are more variants that are coming. There are lots for us to consider as we continue to do this work. And then also being able to think about non-traditional partners. That goes back to who's at the table, but specifically saying those non-traditional people who have had to become those public healthcare professionals in the midst of this pandemic, even though they didn't plan on it, and including them as well. And those, I guess, it's like 2 points with a part 2 on one of those, but those are the 2 things that come to mind.
Thank you, Dr. Gina. Wise words, fresh perspectives and a long view. I like that. Anyone else?
I'll jump in and just add to that because I couldn't agree more. I think that we really not only do we know there's the real reality that we may be having other variations of COVID or another type of pandemic around the corner, but that old healthcare system didn't work, and so like this is a real opportunity for us to truly think about how digital tools may help us overcome some of the challenges that the in-person traditional healthcare system didn't help us solve. We've got a crisis around workforce shortage. We've got fatigued providers. We've got patients that may not have more hesitancy coming into some of these facilities. We still don't have enough access in a lot of locations. We still don't have the affordability that we need to have. There are so many challenges with our old healthcare system, and then throw in a pandemic on top of it. It's a real opportunity for us to take those learnings and move forward. And so having that restlessness for all of us to stay on the course and actually take the lessons learned and push for the pieces that we need to have in place to be able to scale this and continue the momentum. We've got to address the reason it worked is we had waivers. There was a lot of things that were put into place that made this work. So I think that we've got to be very specific around tactical things that we need people to help us with. And it happens to improve the entire healthcare system, not only for a pandemic, but for all the challenges we've been dealing with. It's not the only solution. It's just one of the solutions. And then I couldn't agree more with non-traditional partners coming to the table for us to start addressing some of these social determinants of health and other issues that are real and that are impacting health.
Thanks so much, Dr. Henderson. I really like that. It wasn't working to begin. It wasn't working before. So what do we need to leave behind too? Not only what do we need to carry forward, but what do we need to leave behind? Yeah. Dr. Barnwell, any last thoughts?
Dr. Henderson and Dr. Jeter did an excellent job, took a lot of my comments, but essentially, if we don't learn from the lessons in the past, then we're doomed to repeat them. And like you said, it's an excellent opportunity for us to pivot and make innovation and change. Like she said, Dr. Henderson, if we don't have waivers, if we don't have increased reimbursements, if we don't be intentional in making structural changes and systematic changes to the infrastructure, then there's not going to be any significant progress that's being made on so many different levels of healthcare. So I would just agree with all the comments previously being made. And, the other thing I would say is there has to be increasing willingness to adopt change. And I think with the pandemic, it's catapulted everyone to at least be willing and open to not be stuck in tradition and stuck in the old ways of delivering healthcare. So I think over the next 2-3 years, we have to make, and then what is the standard of the next, what does healthcare look like? Obviously 2 years ago, what does it look like 5 years from now? And what does it look like 10 years from now? And what are the standards of care that are efficient? Like instead of having various silos, what does it look like from a regional level and a national level?
Thank you for that framing, Dr. Barnwell. I want to thank all of the panelists for just sharing their wisdom and depth of experience. I believe we do have some questions from our audience today that I think Mitchell will share.
Yes, and I just will reiterate what Dr. Gagliardi said. Thank you all so much. I am overwhelmed by the wealth of experience and the depth of conversation that we've had today. We're really grateful for your engagement. We do have some questions. One, and I will pose this to all of the panelists. What future telehealth policies would you like to see to help digital health become a ubiquitous offering for people from underserved communities? So again, what are the future telehealth policies you would like to see to help digital health become a more robust offering for people in underserved communities?
I'll jump in first. I guess first, I see telehealth as a modality, and that we shouldn't have a limitation to how we deliver the care. We set quality and standards. So if we can fulfill that through telehealth, where you're located, in those pieces that have been barriers around telehealth reimbursement, and for certain populations being able to access it, or if you need to go be seen first in person before you can be seen over telehealth to be reimbursed. I mean, like all of those, it's way too complicated, right? It's around outcomes, it's around access, it's around experience, and there's all these pieces that if you can still achieve all of that through telehealth, hold people accountable to that, not putting up unnecessary barriers. So I would say it's around removing those barriers that prohibit the full use of it to deliver the care that we do. So treat it as a modality, not one that limits it. It would be like saying, we're going to reimburse only for the laparoscopic surgery versus the one that's an open abdominal, or vice versa. There's a place and time for all of these different ones. So let's make it about that and the outcomes, not the modality.
I keep thinking about those policies that make it difficult to implement telehealth and telemedicine. But I can't skip over the basics of ensuring that people actually have access to care and insurance coverage, and being able to access doctors that they trust, and policies that keep that from happening. And I feel like getting back to the legislation of affordable health care services, resources, it's just so essential before someone can even get to the point of having those telehealth and telemedicine services. So I just can't skip over that piece and get to anything else until we have that. But that's the first thing that comes to mind for me.
Oh, I couldn't agree more. Before you implement a policy, you first have to make sure that everyone has access or availability of the tool itself. And so we already know that 24% of Jordans don't have access to broadband internet, and 30 million Americans don't have access to internet to begin with. So I know in local communities where I live, the school provides tablets to all children to try to mitigate that gap. And so we have to first acknowledge that there are gaps in healthcare. It's like Dr. Henderson said, the system's already broken, so to speak, the way it is. So we have to find solutions to minimize gaps, make sure that everyone has, even though some people have cell phones, they're not smartphones. And so they still can't interface or interact as they normally would or need to. I do believe in hand-ups and not handouts, but what's the accountability portion of each parent or patient or community to do their part in terms of making sure that resources aren't really wasted. So we have some things that we have to do first before we just implement a policy. But those are some thoughts that I have.
Thank you so much for all of those nuanced responses. Mitchell, do we have time for one more question from the audience?
Yes, and I think it really goes back to the very ending of what Dr. Barnwell said. And the question, and I'll again pose this to all of the panelists, what do you see as new technology offerings in the next 10 years to enable more patient access to care and even patient preventive health? So in the next 10 years, what are we seeing? And what are the ideal offerings? And even in our focus groups, we asked, and I'll pose it this way: if you had a magic wand, what would be the things that you would be able to change that we would want to see in the next 10 years?
For me, it would be integrating the various services and providers and having a seamless, comprehensive way of looking at my health. Being able to integrate, my notes and feedback from my therapist, along with my primary care physician, along with my naturopathic doctor, being able to provide and integrate functional medicine as a part of primary care, and being able to have a holistic view, one-stop shop place where I can just understand what's going on with me. I think that 2020 and even 2020 sparked the year of self-care within 2021, and people really are thinking about how they are receiving health, what's convenient for them, what's accessible, and what really works for them in a meaningful way. And so being able to see that and make it seamless and convenient for people without the red tape is what I would want to see.
And I'll build off of that because I want that too. Exactly what Dr. Jeter just said. I think the part that I'm most excited about over the next 10 years is that ability to build more personalized solutions. And technology can help us enable that. So if we'll have more and more data insights that can allow us to build solutions and care teams that meet the individual's preferences and clinical needs as well. So that also enhances, more, it really becomes more contextually relevant. And what I need today versus what I need tomorrow may change, but data can help inform that. And so if you almost treat it like it's technology to create a health marketplace that's customized to me, I can, say the type of healthcare provider that I want and whatever those criteria are that make me feel like I have a trusted relationship and being heard. But I can adjust that. I can bring in self-care tools, whether that's mindfulness, whether that is a specialized health educator for my diabetes. That's the beauty of technology. I can't do that in a brick and mortar. You always have to refer somebody down the street to the next specialist or to the next whatever, which is time and money and transportation and everything else. But if I can have all of that with a click of a button and personalize it, that contextual relevance that data insights can enable, and the ability for us to actually really address some of the shortages of workforce that you have in certain zip codes and, not to mention it's backlogged. I can load bear the work across the country by, tapping into a cardiologist and bringing them into somebody's community instead of the patient having to go to them. So it's about contextual relevance, but it's back to what Dr. Jeter said, simple, convenient, and personalized.
And I will just give a plug for primary care, who really invented personalized medicine, the low-tech version. And so I think that is a real strength of primary care. Any thoughts, Dr. Barnwell, about your vision for the next decade for technology?
If we can do what Dr. Jeter and Dr. Henderson said, I think we'll be well on our way. I would just say, one of the things that really transformed all of our lives is this right here, the cell phone. It gives us increased exposure. Social media platform. So I would say personally, if we can figure out a way how to implement some type of device into our bodies that will actually help with not only to assist with preventive disease. So in other words, it gives us alert if our blood pressure goes high. And then automatically, based upon that, it tells us, hey, your blood pressure is high. Here's some things that you need to do. Here's some therapies. Here's some doctors who are there who assist with high blood pressure. Or here's some diets that you can glean from. Or here's some local workout facilities. So really the integration of healthcare to improve overall healthcare outcomes, but also increase awareness would maybe transform our entire lives. Remote patient monitoring, but integrated with almost like a smart chip that can give people real-time information and device, or even if your blood pressure is high, why don't you send a text message or alert to your primary care physician? So then that way we can know to bring you into the clinic within the next day or so, or refer you to the emergency room so you can get the acute care that you need. Just a couple of thoughts that I have.
Thank you, Dr. Well, again, thank you to all of our panelists and our keynote speaker, Dr. Mack, and to Congresswoman Williams. And I will pass it over to Ms. Walston to close out our convening today. Thank you again to the panelists for sharing their insights.
Thank you all. Please give our panelists, moderator, and keynote speaker some virtual applause. I can't hear you, but I'm sure that you're clapping. We look forward to seeing you back for our spring convening, where we will disseminate more information regarding the study. Fingers crossed that it'll be face-to-face this time. We would like to thank Congresswoman Nikema Williams again, our wonderful panelists, moderator, the United Health Foundation, our fearless leader, Dr. Mack, and you, the audience, for joining us today. Have a great rest of your day and stay safe.